Sure. So the easiest group to determine whether to use single agent or combination with chemotherapy is in the patients who are negative for PD-L1. In that group, there is no approval for pembrolizumab or any other PD-1 or PD-L1 inhibitor as a single agent in the treatment-naive setting, whereas it is approved along with chemotherapy. There is now approval in patients who are positive for PD-L1, but in general, in patients who are between 1 and 49% for PD-L1, I would be certainly inclined to use chemoimmunotherapy rather than single-agent pembrolizumab. It is a cross-trial comparison, admittedly, but the performance in that group of the Keynote-189 regimen versus the control was much greater than what was seen with the single-agent pembrolizumab, versus control. And so, in patients with 1 to 49, unless they absolutely refuse to receive chemotherapy, I would generally use chemotherapy along with a PD-1 inhibitor. In patients who have high PD-L1 expression, in that group of patients, I have generally treated with single-agent pembrolizumab. We do not have definitive data. There is ongoing clinical research evaluating this question. But in general, the outcomes have looked fairly similar, and the toxicity, obviously, of single-agent pembrolizumab is better. The one group that I certainly do consider patients for chemoimmunotherapy, even if they have high-level PD-L1 expression, is among patients who have, for instance, rapidly progressing disease. If they have symptoms that are quite significant, that I worry that there will be progression in a very rapid period of time, and I don't have a second chance, for instance, if I guess wrong, that group of patients I generally have used the combination with chemotherapy rather than single agent. But in general, most patients with high PD-L1 expression, I have been using single agent PD-1, single agent pembrolizumab.